Hello, I'm Pauline Nelson from the University of Manchester, and I'm really pleased to present some of our NIHR ARC Greater Manchester qualitative research, where we went beneath the numbers of the general practice workforce data reporting process to see what was happening. So firstly, some background. Well, the long-term plan highlights that workforce planning in the NHS, including in general practice, has been disjointed and says that this needs to improve. At the same time, of course, we're in a period of rapid workforce change in general practice with declining GP numbers and a planned expansion in non-GP professionals. In terms of workforce data, so the largest available national general practice workforce data set is held by NHS Digital, and data are collected quarterly by the online National Workforce Reporting System. That collects a series of mandatory data, so things like number of GPs, nurses and their contracted hours, and also desirable data, so staff gender and ethnicity, etc. There's also been a number of commercially available primary care workforce data reporting tools that have been used in pockets across England. So workforce planning inevitably hinges upon reliable data capture, but there have been circumstantial reports from GPs of misgivings about workforce data reporting, which suggests some underlying tensions, and that might affect data quality. But there's no literature on how general practice staff engage with the process, and that warranted some exploration. So we aim to examine stakeholder perspectives on general workforce data reporting. Our data were collected in in-depth interviews and focus groups with national, regional, that's across the region of Greater Manchester, and local within Greater Manchester, stakeholders, all of whom had knowledge and expertise in general practice workforce issues. And we used template analysis to work with the qualitative data and generate themes. We sampled across 3 professional groupings. So firstly, national and regional GP and primary care policy leads. Secondly, regional CCG and GP provider leads for each of the 10 areas across Greater Manchester. And thirdly, local CCG leads, PCN directors and practice managers from one area of Greater Manchester with a particular interest in primary care workforce data. And that sampling produced 56 participants in total. And from the data, we generated 3 key themes which highlighted that workforce data quality was actually a challenging issue. And I'll talk through these themes in a little more detail with some illustrative data extracts. So firstly, there were reservations about workforce data reporting. It was viewed as a really thorny issue. So lots of anxiety about that data. Is this going to be used as a performance management tool to bash you over the head with? So worries about who owned the data, who had the right to use it, share it, and for what purpose. And there was also nervousness around sharing workforce data alongside practice activity data. And in some cases, attempts at concealment we heard. So people are quite secretive sometimes about what they actually do. People do not give us the full picture. And that really was said to be getting in the way of any strategic workforce overview, meaning that practices might be making their workforce plans on assumptions rather than on accurate data. So a CCG lead saying we had an ambition to support practices in developing their workforce, but it's difficult to do that without having an understanding what the baseline is so that we can support them in writing a workforce plan. We can help them testing out new roles and how they might fit. Secondly, staff reported overwhelmingly negative views of completing workforce data returns. So the national tool was said to be lengthy, laborious, with a clunky interface, but other tools were reportedly not user-friendly either. Tools were said to lack flexibility and sensitivity to capture the nuances of an individual practice's workforce activity. So I've got loads of nurses, but they don't do the same job. The tool is generic, so I've put generic answers. It's just not applicable. Both GP provider and CCG staff reported that any workforce data they sent to NHS England could sit in a black hole with a lack of feedback. We don't see how it connects into the bigger picture. We don't get it coming back to us in terms of how it's informed policy. We assume that it does, but you don't actually know it does. And I think that made it difficult for practices to understand the benefit of data reporting, and it undermined their motivation to engage with that process. So often we heard that workforce returns were being completed quickly with the aim of just fulfilling basic requirements. So I just do a quick return, and it's not something I pay a great deal of attention to. It's just a box ticking exercise. And this, of course, does raise questions about the quality of data that practices are providing. Thirdly, overcoming the data quality challenge was described as really difficult territory. So not being able to capture full and accurate practice data was said to be setting up a vicious cycle. So it's clear something needs to be done, because without the data, we're going to continue being bad workforce planners and bad workload planners too. So trust and relationship building between stakeholders was recognised as really key to enabling exchange of quality workforce information. And part of that was to try and ensure that practices had a bit more explanation of the underlying rationale for data reporting. So it's about, why do we need this data? What are we collecting it for? And that's been missing before. And I think more fundamentally, people felt that they'd only overcome this data challenge when the reporting process was based around collective working, and primary care networks, PCNs, were identified as a potential vehicle for this. So as a PCN, let's tap into strengths so that I just don't sit in my silo, but actually we play to each other's strengths and we become greater than the sum of our parts. So with financial resource potentially available for network development, PCNs were said to be well placed to start to have real conversations about workforce data, but also perhaps to spearhead a cultural change among practices around workforce data reporting. A caveat here that I must mention was that PCNs had been tasked with many things simultaneously, and workforce data development was said to have to happen over time. So to sum up our contribution, as far as we know, it's the first study to explore in depth the perceptions of a range of general practice stakeholders, so policymakers, GP leaders, commissioners, service providers, and general practice staff about workforce data reporting. And the first, I think, really to highlight that there might be data quality issues underpinned by technical and political reasons. And we think there are three main challenges here. So firstly, a pragmatic surface challenge where you have pressurised practice staff that are completing workforce returns in a rather tokenistic way. A deeper philosophical challenge where the fundamental purpose of workforce data reporting and its benefit to general practice was being questioned. And then a route challenge where some practices sought to push against potential intrusion into their individual business models. And I think the key overall point here is that while technical challenges might be overcome by data system changes, so you can make reporting more straightforward and potentially fix challenge one. The deeper and arguably more intractable concerns, so challenges 2 and 3 here about the purpose of workforce data provision and how that impacts on the economic autonomy of GP practices, may still go unaddressed, meaning that data quality will still be an issue. And that, of course, impacts on workforce planning. So our study supports prior anecdotal reports that we heard of cynicism among general practice staff about workforce data reporting, but the work I think deepens understanding by showing some of the technical and political issues underlying potentially poor data quality. And we know the extent to which GPs share information might partially depend on whether or not this disclosure is perceived to limit their professional discretion. But we also know that collaborative working can help to overcome some of these issues. So perhaps PCNs could be a conduit to better quality general practice workforce data, as they are in part being established to incentivise that sort of collective working between independent practices and give them a voice with policy makers. So to finish with implications for research, the evidence base for workforce planning in healthcare systems globally is sparse and should be more of a priority. But close to home, I think we've highlighted some challenges here that are really quite significant. And it's uncertain in the current climate how much influence PCNs will have in the integrated care systems to try and get general practice workforce planning on the agenda. And I think research on this process will be needed to share learning. For practice, given the many competing demands on PCNs, they still may be best placed to motivate a discussion with their membership about how the quality of general practice workforce data can be improved. And at a broader level, I think there may also be a need for more open debate on the ownership of workforce data and the balance between transparency and autonomy for general practices. Thank you for listening, and you can find more information on our NHR ARC GM work at the link, and please do add your questions as a comment below this video.